All right, class. Sergio Silva Jr. here, doing the week 4 option 1 discussion board video here on lithium. So, a little bit about lithium before we go straight into the main points of this option. It is the oldest known mood stabilizer. It was actually treated in the 1800s for gout. And it actually even used to be used in 7 Up, which I find to be interesting. But I guess cocaine was also used in Coca Cola. So very different times, clearly. But in 1949, by an individual named John Cade, it kind of pioneered these really, really obscure studies that had to do with guinea pigs in urine. He was a prisoner of war. Much too long of a story to tell now, but I'll actually link the old school study from 1949 in my references if you want to check it out. It's a very, very interesting study. But anywho, in 1949, it first began to be used as a mood stabilizer with a lot of, at the time, rigorous studies that wouldn't necessarily be okay nowadays. But it eventually, fast forwarding a little bit, became the gold standard in the 1970s. The fantastic thing about lithium is that it treats both sides of the symptomology of bipolar and some psychotic disorders. But in bipolar, the depressive symptoms, along with the manic symptoms as well. The weird part is that the mechanisms are pretty much, I don't want to say that they are unknown, um, but they definitely are very, very obscure still in the scientific community. We do know that it increases the synthesis and release of serotonin, the rate of synthesis and excretion of norepinephrine in depressed patients and in manic patients. There is a relationship with the blockage of the postsynaptic dopamine receptors, and in terms of their sensitivity, kind of like we were talking about in last week's option one. And yeah, so a few different things like that that we can kind of study, but it's still a very very elusive part of the field, if you will. Um, so let's see here. One of the biggest concerns is that the therapeutic level of lithium is incredibly close to the toxic level of lithium, and that obviously presents an incredible amount of concern in the clinical setting and for the um, recipient's perspective, right? So ways to mitigate this is to monitor, and then to monitor some more. Lab testing is a pretty typical part of this therapeutic treatment. Slowly increasing the dosage as well, and just continuing to test even when the patient is stabilized, to continue to test blood levels and everything for 6 months. And we'll get into a little bit of why this is um, has such an incredibly low therapeutic index. Low therapeutic index essentially means what we just talked about before, that when the therapeutic dose is incredibly close to the legal dose, that deems it a very low therapeutic index. Lithium falls into this category. So let's talk a little bit about why this is the case. Um, so lithium basically goes through the liver completely unmetabolized, right? It's, the liver essentially doesn't even touch it. And when it actually goes through the kidneys, it goes out completely unexcreted, essentially. So the kidney is the main system, or the main organ in the human body, at least, responsible for excretion, and excretion being a biological process essentially to remove any sort of metabolic waste from the body. It's a cleanup system, along with various cleanup systems that the human body has. The kidneys is mostly responsible for the excretion of this metabolic waste. So lithium kind of plays the role of a salt in the body, so it has a lot to do, a pretty significant relationship with the fluids in our body. And so it goes through the liver essentially unmetabolized, comes out the exact same way, and then through the kidneys in a very similar way. So when the body does not really have too much active fluid, dehydrated essentially, the kidneys can begin to absorb more and more lithium, and it starts to accumulate in the system, leading to toxicity. And that kind of brings us into this next point here of signs of toxicity along with side effects, how to differentiate between the two, along with the third point that we're going to touch here in this section, how to differentiate both of those from a manic episode. So some general side effects in general, a little redundant there, but some general side effects are increased urination, thirst, dry mouth, slight tremors, a lot of gut-related stuff, nausea, increased appetite, bloating, diarrhea, that sort of thing. Thyroid dysfunction as well is a really common one. And then the signs of toxicity are a little bit more severe, a little more intense. They could be ataxia, which is kind of like a lack of coordination in your limbs and your fingertips and your legs and things like that. Slurred speech, a very poor attention span, severe tremors, not just shaking, but a little more close to seizures. Really, seizures is also one of them. Comas, severe nausea, severe vomiting, intense lethargy, arrhythmia, so kind of um, a heartbeat lacking rhythm basically, and hypotension and death. Actually, of course, toxicity can lead to death. So when you read these and you think about why is it even a question here to compare this with a manic episode and how they can get confused, is that there is also a lot of irritability and restlessness that can come from this, and that is a pretty key part of mania as well. That's a pretty traditional symptom of mania. However, to really clinically differentiate the two, just assess, first and foremost, assess for goal-oriented behavior, assess for illusions of grandeur or grandiose thinking now. So a little more of these uh, very typical and traditional and hallmark symptoms of a manic episode. Staying up for multiple nights. Okay, sure, those can happen with toxicity and with a manic episode, but why? What are those reasons attached to that? So really just kind of clinical assessment for a manic episode would be the most responsible way to differentiate between the two of them. So a lot of information there. I hope that all made sense. All right. Cheers.